All right. And again, good evening to everyone. Welcome to the 2023 USMLE Step 1 Tutor Series hosted by TrueLearn. Tonight, we'll be wrapping up the tutor series with session number 3, from skill to mastery. To actively participate in the event, same as the other sessions, please use the chat feature located on the right-hand side of your screen to post any questions for tonight's presenter. We will collect all questions and do our best to address them at appropriate times throughout the session, as well as during our Q&A segment near the end. And now we'd like to welcome back our presenter, Dr. Chris Carrubba. Dr. Carrubba is the medical director at TrueLearn's USMLE Smart Banks and has over 12 years of experience in USMLE and complex tutoring, question writing, and content development. Dr. Carrubba, take it away.
Yeah, great to be back here, guys, for the final one here. To avoid kind of, repeating myself too much, I think you can go back and see the previous slides where we've talked about, introduction to question banks, the importance of using test-taking skills, and some of that introductory stuff. Tonight, the goal is really just building upon that and showing you a few more things. And then we've also made some slides at the end to go ahead and answer some of the questions that we've been getting from you guys, either through the chat bar or behind the scenes via email after these. So without further ado, we'll jump right in and, first start off with a couple of skills that I'd like to go through. And one of the common questions that I was getting from people that have attended this, that have sent me emails on it, is dealing with questions with EKGs and how do you approach that? And one of the things that I would want to point out is that I think as you really want to separate practicing medicine in a real clinical scenario versus practicing medicine on a test. And to me, reading an EKG on the exam is very different from what you're going to do in a clinical scenario. I don't know what kind of clinical experiences you all have had yet, but if you're in a clinic reading an EKG, you're going through the leads, you're telling you're attending the heart rate, you're talking about the axis that you're seeing, you're looking at each individual lead. That's not what you want to do on a test. It's going to take way too much time, and it's not really going to help you get closer to the answer. Instead, what you need to do is a combination of evaluate the EKG based on the answer choices that you've been given. What are my possibilities here, right? Like in a real clinical scenario, there's a big variety of possibilities that EKG could show. On the USMLE, it's, usually 5-6 things max. So I've already had things narrowed down for me. You also, as with any media sample, want to take advantage of clues within the text that are going to be able to point you towards the correct answer choice. Even little things like seeing that the patient's age is in the early 20s kind of tells me that it's probably not going to be arrhythmias like AFib or A-flutter there. So usually there will be something that can help you. So taking a look at this one here, one of the first things that I'm going to do on this is, I see that they're asking me for the underlying cause of the clinical presentation. I know that I'm going to have to read an EKG to get it right. I want to go and just figure out what my possibilities are. And you can see how I've went and, like we've talked about before, converted the answer choices over. So right away, I can see my possibilities are Wolff-Parkinson-White. I can see multifocal ATAC, AFib, congenital long QT syndromes. There's an answer that lines up with HOCM, which might be connected to some ventricular arrhythmias. And I can look and see the last one's A-flutter. Next two things that I'm going to really do, I'm going to go back and focus on what I know. I know Wolff-Parkinson-White has delta waves and a short PR interval. I know that the key findings of multifocal ATAC are 3 or more different P-wave morphologies in a given lead. And once I've done that and I've gotten to that point that I've assessed my knowledge, I'm basically just playing a matching game at that point. I'm taking what I know I'm supposed to see, and I'm going and looking at that long contiguous lead at the very bottom, and I'm seeing what lines up. So I look up at lead 2 there. We've zoomed in on it at the bottom of the screen. And I'm saying, okay, does this look like what I see with Wolff-Parkinson-White? No, I don't see delta waves. I don't even see P waves. Okay, move to the next one. Does it look like multifocal ATAC? Again, no, I'm not seeing any P waves, so that doesn't line up. Okay, AFib. Yeah, I know AFib doesn't have P waves. It, has irregular RR intervals. That's exactly what I'm seeing here. And then I could still go through and make sure that I'm checking off and eliminating the wrong answer choices there. But you can see how I've really approached how I look at that EKG based on what my answer choices are. I never once went in and said, okay, I'm going to look at every single lead. Is there a P wave in every single one? What's the QRS looks like? That's just not what you're being asked to do on the test, and it's not a good way to approach your time. Another thing that I could have done here is, even if I was struggling with that, I still could have used some details from the stem. I mean, I could have went and said, hey, it's a 66-year-old patient that makes congenital long QT syndromes and HOCM pretty unlikely. It also makes Wolff-Parkinson-White pretty unlikely, since most of those questions are going to feature young adults too. I can think about my typical MAC question, which is going to be someone that's coming in with acute hypoxemia. Usually on the test, it's a COPD exacerbation. I'm not seeing that here. So even that kind of helps me narrow answer choices down with that. I'm not going to sit here and talk about each one of these, but for those of you that are going back and looking at the PowerPoints, these are the EKGs that I would tell you to be able to verbally describe what you're going to see. AFib has no P waves. It's irregularly irregular. There's irregular spaces between the RR intervals. Be able to verbally do that, and then also be able to look at those EKGs and recognize these conditions. You can see it's not really that many things. And again, it really just comes back to, this is why question banks are beneficial, and this is why you want to narrow your study. I mean, if you want to be a cardiologist down the road, yeah, there's a lot more things you need to learn, but right now, this is where your focus should be to get that good score. Kind of linked into that, I got a lot of questions about how to approach heart sounds. And I'll say here, I'm not able to, through this presentation, share one of the media questions where you're forced to click around on the, interface and hear the heart sounds. But again, I would always point out, when I'm tutoring students, these are usually things that you can still kind of get to, even if you're unable to hear the sound on the audio sample and know what you're actually hearing. What I tell people to do, focus on when you hear the murmur. Is it systole, diastole, continuous? And focus on where you best hear the murmur. Usually doing that is going to be able to break it down. And you can see how I would do that here. If you're telling me that it's systole, or I'm able to at least figure that out from the audio sample, I'm going to be able to eliminate a lot of things. Same down the row, hollow systolic, diastolic, continuous. Same thing over here, where we can really group this down in a generalization and just say, if they're telling me, or it sounds abnormal when I click on the right upper sternal border, it's probably aortic stenosis. If it sounds abnormal at the apex, it's probably mitral valve pathology, or S3, S4. If it sounds abnormal at the left sternal border, it's going to be kind of everything else. That's, it's a generalized approach. It's not going to help you answer every single question. There will be some that probably, really do require you to interpret the sound. And that's where I'd tell you to just go back, over to a YouTube channel, free websites like learntheheart.com. There are lots of free audio samples out there. And, I would encourage you to, just listen to some of those. But again, 85% of those questions you're going to be able to answer from the text, from context clues and critical thinking. So think about that before you go and, spend a full day just listening to audio samples of murmurs. I really wouldn't think that's the most high yield use of your time on that. Moving along to the next part, kind of similar vein, we've got questions with, radiology on there. And again, what I would say, the test is not a cardiologist test. It's not a radiologist test either. They are not assessing your ability to be a radiologist here. Instead, they're usually covering very bread and butter imaging, or they're covering anatomy. Where I see people be inefficient on this is they start finding tertiary resources, radiology texts, books about, radiology for med students, and they start spending a lot of hours going down these rabbit holes. And I would tell you instead, trust your question banks. Speaking on behalf of TrueLearn, when I've made these questions, I've made sure that we are covering the most high yield things. Again, if you came away really understanding our bank or, even the other good banks on the market, you're going to be able to know 90% of what's going to be tested on the exam. So I would really approach this as, rather than just going out on my own and pulling up a bunch of images and trying to go through it, whenever I see a question on my bank that has an image that covers this, I'm going to really make sure that I understand that I understand the wrong images with it. That being said, as you consider the images and you're doing questions to study, look for ways that you can answer it without. And even if you do feel like you understand what you're seeing, make sure that it fits details in the STEM as well. I can't tell you how many times myself, thinking back to step 1, 2, 3, ABEM, that I really felt like I knew what the image was showing. And then I'd look at details in the STEM and be like, well, that doesn't really make sense. That's pointing more towards this disease. At the end of the day, it all needs to line up with that kind of typical presentation that you would expect. So looking over here as an example, we have a question that the big details are, it's a 15-month-old kid, 12 hours of intermittent abdominal pain. They're fine in between the episodes. Recent episode, watery diarrhea about 2 days ago. And then we see a non-tender palpable mass in the right lower quadrant. Looking down here, my first thought would be, I don't even need this image. You've given me enough details here that are telling me this is intussusception. So if I can't look at this image and say, oh yeah, that's the pretty classic target sign, I would instead just focus on, hey, all the details in the STEM say intussusception. Chances are they're not going to throw me some crazy curveball where the image is actually showing something else. And at that point, I can just work through the other answers and say, okay, well, A is pyloric stenosis. That's, not something I'd see in a 15-month-old. Not really what I, would expect in the presentation. Appendicitis isn't even diagnosed by ultrasound. And again, this isn't the typical presentation. Meckel's diverticulum is diagnosed with a Meckel scan, not an ultrasound. So you're seeing, even with some of these, just recognizing that the type of imaging might be related to one answer or another can help you rule a lot of stuff out. So as you go through, again, try to learn those high yield images, but also give yourself that chance to practice. Ask yourself at the end of the question, was there a way that I could have answered this correctly, even if I didn't know the answer? And, really practice doing that. And, that's something I probably want to stop and just say here. I think it's just like a basketball game. Like I've said before, you want to practice the same way that you play. So I think when you're doing these questions, avoid the temptation to just say, I don't know, let me click C and move on, and use that as a chance to practice these test taking skills, because the more you practice it now, the easier it's going to be to implement on your actual testing. All right. Now, so what do I mean by this? One thing we notice with USMLE questions is that they will often become more difficult by choosing to omit information. And that means that the question STEM is going to provide you with less details than you actually would have in a real clinical situation. Maybe they don't mention a physical exam at all. Maybe they only mention part of an exam. Maybe they only give you the CBC and leave out the BMP results. They are doing this to make the question harder. And what you want to keep in mind is this: I shouldn't be making up information. I don't need to fill in the gaps. The fact that they've not given me a cardiac exam doesn't mean the cardiac exam is normal or abnormal. What it means is that whatever information they've left out, they don't believe that I need it to answer the question correctly. That's how I think when I'm writing a question. I am leaving this detail out to make the question more challenging, and I'm leaving it out because I believe that independent of it, I've still given you enough information to answer this question correctly. And that's how you should approach it. You essentially say, hey, I wish there was a cardiac exam here. It would have made it a lot easier if it was. Maybe it's positive, maybe it's negative. I don't know. Let me just focus on what details I have. Here's a good example of that, and we're seeing two different ways a question can show up. So in the very top, these are both going to be examples of cardiac tamponade. In the very top example, we get everything we want to see. We see all of Beck's triad. They have hypotension, they have jugular venous distension, and they have muffled heart sounds. Very straightforward. And what you notice is that maybe it's straightforward because they're not asking you for a diagnosis. We're instead asking you to predict an EKG finding. So maybe we're making that part a little bit easier. Moving over here to this other question, though, what we see is that now we've only given you jugular venous distension and hypotension. We've not said the cardiac exam's normal. There's just no mention of it at all. So in your mind, you should say, I can't say it's normal. I can't say it's abnormal. I just need to focus on the details that are there. What are those details that could help push me there? I see that the patient has recent motor vehicle collision and chest trauma. Okay, that's a risk factor for, tamponade. They have chest pain. They still have 2/3 of the triad, and I just don't have a cardiac exam to go on. And lastly, they have electrical alternans, which I know is an ECG finding that goes with tamponade. And at that point, I say, hey, I've got enough information to recognize this condition. And really practice with this, because I can't tell you how many times in a tutoring session I've had a student get there and they say, well, this really looks like tamponade, but that patient would have had muffled heart sounds. And it's like, you're right, but that information is just not here. And that's really how you have to approach that. And that is a very common thing on step 1, step 2, step 3. And I think that being able to handle the omitted information is what can really help people sometimes make 10, 20, 30-point jumps just because they get so good at doing that. As we move to the last slide here, I wanted to pick a really hard question and just show how you can put this all together. So in this question here, we see that we're asking for the most likely cause of the patient's EKG findings. We've got a lot of answers, down there. So we're going to move just right up to the top. We see we've got, young guy, 2-hour history of severe tearing chest pain and shortness of breath, no recent trauma, history of Marfan syndrome, no other, risk factors in there. We see he's tachycardic, hypotensive. We see he's got, pretty significant JVD, some exam features of Marfan's. He's got clear breath sounds bilaterally, no other abnormalities on exam. And then we look at the EKG and, we can see some electrical alternans and we can see some, widening of the mediastinum. And again, there are people who right away are going to just pick all of that up and they're going to be able to say, yeah, there's tamponade there, that's really tying in. A lot of people struggle with this question because they see the severe tearing chest pain and they instantly say, oh, this is easy. It's an aortic dissection question. Aortic dissection isn't an answer choice. So again, let's move through that in steps. We always start by saying, what do I know? I know this is someone with Marfan syndrome. I know that this Marfan syndrome patient with tearing chest pain is most likely having an aortic dissection. Aortic dissection can certainly explain the widened mediastinum on the chest X-ray. However, the problem is the aortic dissection, 1, just isn't an answer choice, and 2, isn't going to be able to explain the EKG findings. It's not going to be able to explain the JVD. So right there is where I take the pause and say, okay, they're probably testing a complication of aortic dissection. It's probably going to be an answer choice that is related to that. Right away, tamponade's the only one that's going to really jump out as a complication that's going to get tested. And then I can look in and say, does it fit? Yes, it would give me the JVD. Yes, it would give me the electrical alternons on ECG. Yes, it would explain the clear lung sounds that I'm seeing. And then I can just work through all the others and say, okay, even if I didn't make those connections, I can use process of elimination. And I can say, okay, pericarditis isn't going to work because 1, it's not a complication of aortic dissection. 2, it doesn't typically give me JVD on the exam. 3, the EKG that I would expect for that is actually diffuse ST segment elevation. C, hyperkalemia. It doesn't work because it's not tied in as a complication of dissection. It couldn't explain the JVD. With that, the ECG should be showing peaked T waves. Hypoxemia, is going to be more associated with MAT. We're not seeing that here. Instead, we're seeing electrical alternons. MI is really the most tempting wrong answer choice here because we see that the patient has a mild troponin bump. However, the EKG does not fit. We're not seeing localized ST segment elevation. If this were an MI causing JVD, I would also expect them to have bilateral crackles from pulmonary edema, not clear breath sounds. And then 3, I can feel good about the troponin being bumped because we know you can actually see a little bump with aortic dissection. So that's fine. And then lastly, I can get rid of pulmonary embolism because not typically a complication of aortic dissection. On ECG with that, I'm most likely going to see sinus tachycardia, or I could get that S1Q3T3 pattern, but again, not really electrical alternons. So even though this is a very challenging question, you can see there's a lot of ways to get it right, whether that's you feeling really confident about it up front or you using really good test taking skills to work towards that answer choice. All right, so where I wanted to wrap up here for the night and kind of transition over to is really making sure that we, had some slides that answered questions I've been getting from you guys, either in the chat bar or offline after the sessions. And I felt that was really just titled and focused best under kind of maximizing, learning from these banks. So one thing that I think you should always pay attention to when you're going through, whatever bank you're using, and, again, most of my talk is going to come from experience with TrueLearn's bank, are, comparison tables. And that could be ones that you see in the bank or ones that you start making yourself. And I think comparison tables are really high yield for the USMLE because they are a great way of differentiating things that I know get tested against one another. And I think these are great when you find yourself saying like, I can never tell if it's PBC or PSC. I have a hard time picking Crohn's from UC, or just anything that you either know gets tested a lot together or feels like, is pretty related. And you can see, a good table here. And, I think to me, what a good table represents is going to be something that's very succinct, very minimal text, and is able for you to quickly look at and scan side to side and see key differences. So I could look at this table and say, hey, acute cholecystitis, choledocholithiasis, maybe that gives me some problems because they both can give me acute right upper quadrant pain. They both might have a history of gallstone disease. And then I can start looking through and figuring out where my key differences are. And, you can see, okay, the cholecystitis patient, I notice in questions typically has pretty normal LFTs, whereas the choledocholithiasis patient has signs of cholestasis, the elevated alk phos, the conjugated hyperbilirubinemia. I can look at the key differences in abdominal imaging. And so that to me is what a good table is, whether you're reviewing that, something that's, been made like you'd see in our bank, or if you're just trying to do that on your own as a way to study, that's how I do it. And as you go through these, keep in mind, you don't need to sit there and write down the table on your own, recreate it, or try to memorize it all in one sitting. Instead, just keep it as something that you come back to over time. Save it, put it off to the side, and next time you see a question about gallstone disease, pop it out and go through it and just look and say, hey, would this information have helped me answer this question correctly? Maybe what parts of it did I forget? And go from there. And you can see there's lots of different ways that you can make a table. This first one here was really focused on clinical presentation. Moving over to here, this is just an easy way to group different mechanisms and risk factors for gallstone formation. I think there is a broad way that you can apply tables. We've tried to do that for you in our bank, but it's something that I think with a little bit of practice, you can always do on your own to study as well. Another thing that banks are really helpful for, and this is probably the thing I try to push people on the most if I ever get any pushback that maybe they don't want to do question banks. I think banks are really good for learning diverse presentations of a disease. And I think you want to keep in mind, and this is where I always see people struggling at the beginning of their studying, is that not every question about sarcoidosis is going to look the same. And it's easy when you're looking at a textbook and you're just, okay, these are the symptoms, da 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 da. You almost end up coming away with a picture in your mind of just, one stem for sarcoidosis, one stem for tamponade. And then where people start to struggle is that when they get in the bank, they're seeing that things are written differently, that some stems focus on this detail, others focus on this one, others include the PFTs, some omit the PFTs. I think banks are a really great way to learn the diverse ways they can throw a disease at you, especially if you start using multiple banks, as well. So you can look here and, I'll let everybody come back to this when they, see the slides, but you can see there's 3 questions on abdominal aortic aneurysm. Every single one is using a very different details. The first one is talking about severe abdominal pain. The next one's talking more about flank pain. You're going to see just different details as you work through there. I think the key is that you can use this to say, what are the common denominators? There are going to be things that I can go through and find that look the same. And then you can also say, what are going to be the various differentiators? And, you're again seeing that here in this sarcoidosis, bit. You have some of these questions that are throwing a lot of laboratory findings at you and really focusing on that, the hypercalcemia that you're going to see. You're going to have another question that's showing you that, sometimes sarcoidosis is going to get tested in a man, and approaching these questions thinking that you would only see a female patient isn't going to work. Some like you're seeing here, sometimes they might describe the imaging to you. Other times they might actually show you the chest x-ray and interpret it yourself. So seeing these questions, doing more of them is really going to give you that diverse presentation in your mind. And, I think it's a mistake walking into test day saying every question I see on sarcoidosis or whatever disease is going to look just like this. It's going to fit neatly in this box. And instead, what I tell my students is that as you're going through the bank, you should be really thinking more about what are the combinations of details that could be there. And this kind of, broader picture is what sarcoidosis looks like. And the question is going to feature some combination of those details. And, then as you step along that, you can start to see, okay, what are the things that they tend to test against this disease? What are the things that typically are wrong answers? What are the details in the question stems that might help me move back and forth between the right and wrong answers, things like that? And I think doing questions, whether, regardless of what bank it is, I think that's probably one of the biggest benefits you get from them, is just seeing how many different ways this can be tested and really giving yourself the chance to develop that mental bank. And, what I would do to quiz myself on that is just, I'll ask students, okay, tell me what a typical stem about sarcoidosis could look like. What are the details that could be there? Are there details that are always there? What are things that maybe won't be there? Things like that. So, again, make that mental bank, challenge yourself to start thinking that way. Other things that you can get out of question banks are really practicing how you make inferences as you walk through the bank. And depending on where you are at in your studying, you might know what I'm talking about here. And I made sure to put some examples in, but there's just points where the USMLE is going to ask you to infer information that they've left out. They might say the patient has lupus and they are on appropriate medications. As you go through the bank and learn, you're going to get to that point where you say, okay, stop. What are those appropriate medications? Well, if they're lupus, it's probably setting up that this could be a prednisone related question. Maybe it's going to be Cushing's disease, or maybe they stopped it suddenly and it's adrenal insufficiency. You could see one where it's like, okay, the patient previously underwent major abdominal surgery after trauma. They've got a big scar on their abdomen. You want to get to where you're stopping and saying, well, could that be related? Well, they're coming in with a fever. Maybe they had a splenectomy, and the loss of the splenic function is contributing to a current infection. Patient works in blank occupation. They work in aerospace, engineering. Okay, well, that could be a proxy for a risk factor to beryllium exposure. If they're a sandblaster, it's a proxy for telling me that they could be exposed to silica. Doing practice questions as you go, just pay attention to spots where you might need to be making those inferences. Another good skill to work on, focus on learning more than just buzzwords. People always, when we have tutoring sessions, especially, they can say, oh yeah, Burkitt's lymphoma, that's going to have the starry sky pattern. They are not going to say that on the test. They will never say biopsy, lymph node biopsy shows a starry sky appearance. Instead, they're going to say, on biopsy, there's lymphocytes with numerous mitotic cells and apoptotic bodies. Or they might show you the image instead. Same thing for radiographic findings. You're never going to see a question that says, the barium swallow shows a bird beak sign, or, you're never going to see them tell you that for Hodgkin's lymphoma, hey, on lymph node biopsy, we see a Reed-Sternberg cell. Questions are really going to show you the technical way that biopsies, that x-rays, that EKGs are described, and they're going to show you what visual images you're actually expected for. So again, as you go through, those are things that I always thought were great to put on flashcards. Okay, Burkitt's lymphoma, yeah, I know the starry sky, but maybe I need to make a flashcard for the actual biopsy finding that I'm going to be, held accountable for. Another thing I wanted to bring up with is just the idea that the question is lying to you. Again, I think I said it during the second session. You're better off always coming in thinking that they are not trying to trick you. And that comes down to what the patient is telling you as well. The majority of question stems, like 98% of them, you should approach it as if the patient is being honest. You don't want to be saying, well, the stem said, the patient says they drink 1 to 2 alcoholic drinks on the weekend, but maybe they're lying and they drink a lot more. Most of the time, that is going to lead you down an incorrect path. There are going to be exceptions, but they are going to be painfully obvious on the test, and you'll see that as you do questions. Maybe it says they don't use illicit drugs in the stem, but in the examination, it says there's multiple track marks down their, arms, and they have symptoms that suggest infectious endocarditis. The patient says they've never been sexually active, but they have clear signs of an STI on genital examination. They tell you that their 2-month-old kid rolled off the bed in the stem, but you should know that a 2-month-old kid is not able to roll. Those lies are going to be pretty painfully obvious. And again, I think a good question bank is going to be written to know what are the ones that you're most likely to see on the test, and we're going to give you that chance to practice it. So coming up here on some closing thoughts, just to leave some time left over for questions here at the end. I wanted to talk a little bit about the transition to pass fail and a couple other, little things here. I said it last time, the transition to pass fail certainly has some benefits to it. I think benefit number one is that you have the ability to pass on some material. You got to be careful about that. Too many students now are really extending that. And it starts off as, I don't want to learn the biochem pathways. And it gradually moves over to, well, I also don't want to learn the biochem disease, the enzyme deficiencies for each disease. Now I don't want to learn the presentation of each disease. Now I just don't want to learn biochem in general. If you are going to try to pass on things, you've got to be careful about it. I think you can use your question bank to guide you, but really for the pass fail test, what I'm seeing is that if you're able to get the questions that 55 to 60% or more of students are answering correctly, and you're reliably getting the bulk of those, plus some of, a handful of the others, even if you're guessing, that's going to be enough for a passing score. So I would tell you that as you're studying, especially if you are in a position that you're, pass fail, you're on the fence, you've got, maybe 3-4 weeks to go, it probably is okay to really focus on that high yield material at that point. You can move a little bit away from minutia because the score, isn't going to be there anymore. And I think you can, focus on resources that are really going to help you with that, as opposed to, maybe diving into things that are covering minutia that, you're only seeing 20% of people answer correctly, and there's probably only a 1% chance of it being on your test. That being said, you've got to be careful. First and foremost, like we said last time, the failure rate has increased. I think there's a couple reasons for that. One, a lot of schools are now giving people less time for dedicated studying. Along with that, some schools are even just spending less time teaching to the exam and saying, oh, well, it's pass fail now. We're going to go back to maybe being a little focused on what we want to teach and not as worried, about that. On I think the student side, a lot of people are saying, well, I don't need to worry about it. There's a lot of material that I can punt on. I don't need to give myself as much time. So, the biggest thing I would say is still take it very seriously, still treat it as being important. Be very careful about punting on things. Another consequence that we're seeing now, as expected, step 2 and shelf exams are starting to mean a lot more. And I'm talking to a lot of students now that are saying that their visiting student rotations or their audition rotations are now sometimes requiring a step 2 score for placement to even get that opportunity. So it is potentially forcing people to take step 2 a lot earlier, which could mean maybe not giving themselves a dedicated time or giving themselves a very brief one. And I think that's really highlighting the importance of learning good test taking skills now for step 1 and having that in your back pocket, that's something that you are strong at and can really, use on your shelf exams to do well. It's a very important skill there, and carry over to step 2, with that too. In order to maximize your chance of passing, things that I would want you to take away, it's never too early to start studying and to start doing questions. Even for people right now that aren't yet in dedicated, maybe they've got a month or so to go before that, I would tell you to start doing something, even if it's just exposing yourself to 5, 10 UWorld questions or TrueLearn questions a day, just to get used to that. To start learning how you're going to do it, the amount of time it takes you to do, how you're going to, review it, how you're going to approach test taking. That would be, a lot. That's a big step and is going to make a big difference, even something, little like that. In terms of practice examinations, I would recommend taking an NDME practice exam prior to beginning dedicated, just to get a feel for what your strengths and weaknesses are. very often, if not a majority of the time, it ends up being a lot different than what you think. And I can't tell you how many people have said, I'm going to be great at this and bad at this, and it's completely flip-flopped. You can also use that to really get a feel for how much time am I going to need to study? What are the things that I'm going to need to focus on early? What are the things that, maybe aren't as important as I thought they were, things like that. And I think once you've done that, you can really sit down and create your study plan with a goal of getting through at least one bank, doing all of the TrueLearn bank plus the incorrects, or even just working through, multiple banks, which, I would still, going back to the first one, say that it is better to try to get through multiple banks because, again, thinking back to what I just said about getting that diversity, again, TrueLearn isn't writing the USMLE exam. UWorld's not writing the USMLE exam. So I think the more diversity you can see, the better equipped you're going to be for that test. You're going to have seen more permeations of how a question can be written. Start focusing on repetition. We talked about it earlier, in webinar 1. You really want to focus learning on stages, as opposed to trying to maximize everything once and then have to move on to where, things kind of start to go down because you haven't seen them a lot. So try to make a plan that allows you to get a lot of repetitions. And then as you go through it, focus on a plan that works for you, that it is good for your way of studying, and be careful about how you deviate from that plan. I think too many people, are changing their plan for week 1, week 2, week 3, week 4, and they would have been better off just sticking with what they had. So I think you want to be really cautious about that. And I think where you really can maybe start to make decisions on how to change what you're doing would be your assessment examination. So we said, up front, try to take one at the beginning of your dedicated. Your next one, I would say, and it's going to be different for each people, but it should be after you've got a decent first pass through a review of the material. What I don't like is when, let's say, somebody takes, their very first NBME practice exam, and let's say they fail, and then they decide they're going to take another practice assessment a week later. The chances are you've not done enough in that week to make a huge dent in what your score is going to be. So in my opinion, in that situation, it's almost like you're wasting that exam. You're using it at a point where, I'm probably going to fail because there's a lot of stuff I haven't even reviewed yet. I think it's better to, if you have the time, backload your practice exams so that you can set it up to where maybe you're taking one a week, getting through all of the NBME ones up until test day. And by doing it, usually about 5 to 10 days apart, I think it gives you enough time to say, okay, here's what I did well, here's what I did bad at. Let me spend the next few days taking some time to address those things. You want to give yourself enough time to address those weaknesses. And that's why I would also say, don't take one practice exam today and another one tomorrow. Chances are you're not going to have done enough to fix those weaknesses. As you go through, you'll also want to think about building stamina for test day. If you were going to run a marathon, tomorrow, you wouldn't just start running for the first time earlier in the week. I think what you can do, especially if you find that this is something that's hard for you, start stringing together 2 or 3 timed blocks, in the 2-3 weeks leading up to test day to really get a feel for what that's going to be like, how you might get tired. I would suggest making sure you're doing UWorld or TrueLearn questions at the exact same time that you are going to be taking your test. If I know my test is at 8 in the morning, I want to make sure that I start mimicking that, getting up, doing that. I have a lot of students say, well, I'm just not a morning person. I like doing my questions at 1. Well, when's your test day? Well, it's at 8 a.m. All right, you need to start getting used to that. Anything you can do to mimic what the real day is going to be like will be beneficial for you. Keep in mind, too, that the practice exams only add up to about a half test. So if you're really worried about this, you might want to string 2 practice tests together simultaneously, or what I would typically recommend is do a practice test, which would be about half the test, and then get that other half on your question bank. Again, another thing I get is people saying, what about reschedules? How should I do this? I mean, it's a very individualized question that usually, takes a lot of talking to that one person. But I would tell you, don't be afraid to reschedule if you're not passing your practice exams. If it does not look like you're going to pass on the practice exams, even if you're getting pressure from someone, I would tell you to be really cautious about moving forward. It's always going to be worse to have a failed attempt than it is delaying the examination. Again, you can come back from it. I know people who have failed step 1 that have went on to match in orthopedic surgery, but they made their road a little bit harder that way. So if push comes to shove, when someone asks me, I would always say that it's a little bit better to delay and be in a position where you have a very good chance of passing than taking it, with a high risk of failing. As far as biostats goes, a common strategy I see is people saying, oh, I just want to save biostats for the end. I would not do that. First and foremost, you don't know what you're going to be struggling at. You don't know what's going to come up in life that might delay your studying. Having a situation where I have to do all of this in my last few days is usually not a good place to be in. What you can do is focus on this. The USMLE tends to test the concepts a lot more than the calculations. It's a lot more important that you understand how to interpret results. What is sensitivity? What is specificity? What is an odds ratio? And apply that than it is to do the calculation. So I would say at a minimum, start working to understand the concepts, start doing biostats questions on day 1. And if you're putting anything off till the end, I would just maybe keep that at the equations themselves. Here's how you calculate PPV, NPV, sensitivity, specificity. That's something where expose yourself early, but if you want to go in the last 2 weeks and really try to memorize that, that's probably fine. But again, don't start adding too many things to that pile of, I'm just going to do it in the last week. We've said it enough here, keep working on your test taking skills, start practicing them now. Within our bank, we've built the insight section so that it does cover this. And if you've liked what you've, been exposed to here in these sessions, we have tried to expose that in our insight section. And then it was really important to me to put this in here, but just a couple things that I would want to end on is, first and foremost, no test defines you, and no test defines your worth as a person, your worth as a physician, your ability to be a great physician. Some of the best doctors I know are people that struggled with step 1, maybe didn't even pass it on their first attempt. So just keep that in mind. This test is not the only referendum on your skills and your ability and your intelligence. So keep that perspective. And then as you're going through, keep in mind your own physical and mental health, because I think it does make a big impact. And I've never had a student that I've worked with who I felt that they were better off because they were studying 10, 11, 12 hours a day, because they were, never taking a day off, because they were neglecting every single thing in their personal life and their own health. So I would encourage you to just keep in mind, you're not a robot, and this is a marathon, not a sprint. So find something that makes you happy and, feel connected to people in your life as you're going through this. And you can take half days off. You can even take 1 day off if you structure things appropriately. Most days, 8 good hours are enough, and you should focus on that quality over quantity. Get outside in the sun. Make sure you're getting, 7, 8 hours of sleep. Try to get a few hours of physical activity in a week. Those are things that they're going to keep you healthy as a person, but honestly, there are things that are going to improve your score. And, sometimes those are the easiest interventions for me when I'm working with someone, is to just say, hey, if you started doing this, I think your score would go up. And, most of the time it does when people actually embrace that. So It's been a privilege for me to have the opportunity to come in here and do this with you. It's something that I feel really passionate about. Any of you feel free to, reach out to me with questions, to TrueLearn with questions, and, good luck on your test.
Thank you, Dr. Carrubba. We'll get into just a few questions. Any advice on handling questions with other types of images besides those that you covered, like clinical photos, for example?
Yeah, I mean, I think most of it lines up the same. So let's say biopsies, for example. Like, a couple components of that. Component one, I would say use your banks to figure out what you actually need to know. You should get a good feel for, like, hey, they definitely tend to show me Reed-Sternberg cells. They very frequently show me the Burkitt's biopsy. Those are things you should try to actually learn that image. But even on those, you can usually use a combination of things in the STEM to help you. I mean, one of my favorite tricks to teach people is, like, we know leukemias and lymphomas are often tested against one another, but you diagnose lymphomas with a lymph node biopsy, leukemias with a bone marrow biopsy. So even just telling me where the biopsy is coming from will often let me eliminate a good amount of answer choices. From there, I can go back and look at some of the clues in the STEM, and it's like, okay, well, it was a bone marrow biopsy, but this person is 50. So it's probably not going to be ALL. It's also probably, not going to be CLL because they're a little bit young for that. I can look for just common buzzwords like, hey, questions about AML very frequently use chronic DIC as a presentation. So they like to focus on gingival bleeding and nose bleeding. So I think usually there are going to be details in the STEM that can help you, even if you don't know what the biopsy is showing. And so I think with any image, if I truly look at it and I say, I just don't know what I'm seeing, I'm going to do a combination of, what conditions could I get rid of because this image, this biopsy location wouldn't help me? And then what are the details in the STEM? What's that pointing me towards? And then, I think another place you can see images or just, illustrations like, pressure tracings for, different valvular diseases, or, maybe some illustrations on biostats questions. And we covered that briefly in webinar 1 if you want to go back to those slides, but I would just tell you to try to look at it and verbally interpret what you're seeing. Okay, I noticed that the pressure curve is doing this, and I think if you can put those into words, sometimes it can often help you, especially if you're looking back down at the answer choices and maybe relating it into that, or you're looking at the STEM and able to figure out something that you do know.
Thank you. And another question. Are there some presentations that may be too rare to appear in a question that are too diverse, so to speak?
I think this is where I come back to focus on your question, Ben, right? Like, we think about diseases, like sarcoidosis has so many different rare presentations you can see, or even things that I would say aren't that very rare clinically. I think what you want to focus on is, what are you seeing in your question banks? Because chances are the real test is not going to deviate outside of that. So the real test just does not test rare things. So they're going to focus, especially on step 1, on very bread and butter content. So I would truly use your question bank as a guide. And I would say, hey, if I've never seen a question where sarcoidosis looks like this, chances are the question I'm looking at now isn't a sarcoidosis question. So yeah, I can never say never, right? Like, they could always throw some crazy one in there, but that's not what you need to be able to pass. You need to be able to go focus on the bread and butter. And if you're going down a rabbit hole for every disease, and it's like, well, here's the case of sarcoidosis that presented with joint pain, and you're going into test day with sarcoidosis on your differential for someone that has elbow pain, that's going to hurt you way more than it's going to help. So use your bank and just focus on bread and butter as to how that guides you.
Thank you, Dr. Carrubba. Another question. When do you think we should stop practicing questions before test day?
I think that to me comes back to like when you should stop studying in general. I mean, I personally don't believe that you get much, you know, out of anything from the day before. So if test day is on Friday, I typically tell my students to stop studying like, Wednesday night. I just really don't think there's much to be gained from studying Thursday, and you're usually going to go in, a lot fresher if you can just rest. That being said, it's really hard advice for people to take. So I really have nothing against somebody studying the day before. I would tell you, you're probably still best on that day to maybe just flip through flashcards or like high yield memorization facts that you want to see one more time. But, even then, if someone said, I just want to do, 10, 20 questions to stay on my game, I wouldn't be opposed to that. But pretty much right up until then, I would be doing a lot of questions, and I would actually be, probably ramping my, I would be going with a high volume of questions in those like final days, just to make sure that I'm exposing myself as much as possible and, getting what I need.
Thank you. And when using a question bank, is it best to read the entire explanation? Okay, just to skim or read certain parts? What do you think?
It kind of comes down to where you're at. I mean, I think it comes down, I think, for individual people and your performance. And is it the first time you've seen that question or the second? So I think that let's say on one end, you've got somebody who is just starting their question bank for the very first time. They're missing a lot of content. That's somebody who I really think should probably be going through all of it. And, we talked about in webinar 1, if you want to go back to kind of that framework of like, what was being tested here? What did I need to know step by step? What did I, why did I miss it? What misinformation do I have? That would really serve as a good framework, versus someone who is a little bit further along, maybe doing well. You might not need to read everything. If it was a question where I could go through and I'm like, yeah, this is easy. It's bread and butter sarcoidosis. I understand exactly why that's correct. I understand why every answer is wrong. Might not need to read anything, or you could certainly skim through it. So I think it's going to be different person to person. And even within one person, I think it's going to be different question to question where they're at in their study plan.
Great. And I think this will be the last question, but any tips for handling ethics, communication, those kinds of questions?
Again, start practicing early. I think your banks are the best way to get exposure to that, because ethics is such a broad topic. We hired someone specifically to work on that for our bank and make sure that that's, really highlighted there, just because that is the best way to learn it. So I would get into those practice questions and really use those, because I think ethics is probably one of the hardest things to learn just looking at a book. And you can certainly learn some of the principles there, differences between Medicare and Medicaid, things like that. But I think the real nuances of, how you're supposed to approach a patient interaction, that really comes from doing questions and, making sure you're working with a good bank that has, prioritized that, because it is an important part of the test. And it's, one of the things that probably is best for learning, with questions.
Great. Well, thank you, Dr. Carrubba, and thanks to everyone for attending From Skill to Mastery, the final session of the 2023 USMLE Step 1 Tutor Series. Few final notes as you guys head out. Within 24 hours, you will receive a follow-up email containing a replay link to the recording of tonight's session, an option to download tonight's slide deck, as well as replay links and slide decks to session 1 and 2 as well. So you can review the entire series at your leisure. Additionally, this email will contain an exclusive offer code good towards any USMLE Step 1 Smart Bank or bundle. And of course, as always, TrueLearn does offer a completely free Smart Bank trial that you can access simply by visiting truelearn.com, navigating to the USMLE Step 1 product. On behalf of TrueLearn and Dr. Carrubba, thank you all so much for joining the 2023 USMLE Step 1 Tutor Series. So on behalf of TrueLearn and our presenter, thank you so much for joining us, and you have a great rest of your evening.